Here we have a 65-year-old self-identified white woman who comes to the office for a routine follow-up exam 6 months after completing adjuvant therapy for stage 3 adenocarcinoma of the sigmoid colon. Her prior treatment consisted of partial colectomy followed by a 6-month course of systemic chemotherapy with oxaliplatin, fluorouracil, and leucovorin. All right, so I'm going to go ahead and highlight these important facts here. 6 months of adjuvant therapy for stage 3 adenocarcinoma, 6-month history of systemic chemotherapy with these 3 agents. Due to prolonged post-op recovery period, she reports that she's been mostly sedentary and inactive at home. All right, that's important to note. This patient now reports a 4-week history of progressive pins and needles sensation, numbness in both of her feet, as well as noticeable decrease in sensation in her fingertips that make it difficult to turn the pages of a book or fasten her clothing. So I think this would be basically their chief complaints. So things worth highlighting here. 4-week history of pins and needles, sensation of numbness in both of her feet, and then decreased sensation. Okay. Her medical history is otherwise unremarkable. She takes no daily medications or nutritional supplements. Temperature is 98.2, pulse is 72, respirations are 14, blood pressure is 124/78. She is 5'4", weighs 84 kilograms, BMI is 31.6. On physical examination, her abdomen is soft and non-tender with a well-healed surgical incision. Neurological examination reveals a symmetric decrease in sensation to pinprick and light touch over all fingers and toes. All right, so that's an important physical exam finding. Motor strength is 5 out of 5 in all extremities. Deep tendon reflexes are normal except for symmetric trace ankle jerks. All right, so it looks like the strength is intact and the deep tendon reflexes are pretty much normal and consistent with her age. So which of the following is the most likely underlying cause of this patient's condition? So working through these answer choices here. So A, deconditioning from prolonged inactivity during cancer therapy. This would make sense. However, this patient's strength is intact, and their rating is at 5 out of 5 in all extremities. So if it was decondition related, you would think more muscle atrophy. And since strength is 5 out of 5, I'm leaning away from a muscle atrophy kind of a presentation. Her presentation really here is numbness and tingling, specifically in the fingers and toes. So that sounds more like a peripheral neuropathy kind of a picture. B, metabolic imbalance directly related to her underlying malignancy. So I would suspect this if there was any signs that the malignancy was still present. The fact that she was treated 6 months ago with looks like a surgery and chemotherapy, it's less likely that there's any kind of malignancy that's still driving this presentation. So I'm going to sort of move past that one for now. Microvascular injury secondary to chronic hyperglycemia. So that's referring to diabetic neuropathy. And typically 4-week history of this pins and needles is not consistent with diabetic neuropathy. Typically you would see diabetic neuropathy happen over the course of several years. And it doesn't sound like that's what's happening here, so I'm going to move away from C as well. Some of the other microvascular things you would think about is retinopathy and some kind of kidney disease progressing as well if you're thinking that this was all related to her diabetes, which doesn't seem to be the case, but she has the risk factor of being, having a BMI of 31.6, which could put her in the bucket of being high risk, but doesn't really indicate that she is diabetic or being treated for that. The multi-level spinal spondylosis with compressive radiculopathy. So if there was some kind of a compression radiculopathy, you would see also muscle weakness. So while you do see pins and needles kind of like a neuropathy picture, you would also sometimes see muscle weakness or even loss of sensation and dermatomal distribution based on wherever that impingement is. And so since you don't see that here, you can sort of move past that as well. And then lastly here, toxic neuropathy from systemic neurotoxic pharmacotherapy. This is basically getting at the fact that this patient was on chemotherapy, which is known to cause many symptoms, one of which is peripheral neuropathy that is most common in the distal extremities, so the fingers and the toes. This particular medication has a different mechanism. The other one that's classically associated here